Good afternoon and welcome back. Welcome back to the 81st convening of the Presidential Advisory Council on HIV and AIDS, also known as PACHA. Really want to thank our morning presenters and discussants around digesting what was some alarming yet enlightening information about our path forward and really some focused conversation on where we might want to intensify our efforts next. So I really want to thank and give a round of applause to what we've heard already for today. Yes, we are going to move promptly into our afternoon conversation with our federal partners and colleagues. The title, The State of HIV in the United States, Progress to End the HIV Epidemic from Agencies' Perspectives. So this panel will again be facilitated by PACHA members and Dafina Ward, who co-leads the Stigma and Disparities Stigma Disruption Work Group, and long-term PACHA member, leader, consultant, therapist, all the things for PACHA, Dr. Dara Wheeler. And this will be a fairly extensive panel. So we do have scheduled breaks in between speakers, but I will now turn the floor over to the two of you. Thank you, Daryl and Dafina.
Thank you very much, Marlene, and welcome back this afternoon. So as we begin our panel, I do want to underscore two things that Marlene said. One is the illustrious presentations this morning, from the opening and the contextualization right through, and also underscoring that we have a very jam-packed set of speakers, and so I want to make sure we give them time. Going into this, and Dafina and I had the opportunity to meet a few times over this, and thinking about the title, The State of HIV in the United States, Progress to End the HIV Epidemic from Agency Perspectives. If you think about the presentations this morning that laid out the interconnectedness, or the term that I was using in prep for this was the scaffolding that has to occur across agencies to create the mosaic, the network, to be able to do this work is complex. And I think it is befitting because, as we heard earlier, in HIV and for these 43 years, what HIV has forced us to do is to deal with an all-on healthcare crisis, meaning that the syndemics, the infrastructure, the behavioral sciences, the biomedical sciences, housing, all of these issues had to be brought to the table, and it continues to grow. Now, in the 249-year experience called the United States of practicing to get something done, and I say practicing because it is not refined, it's not done, it's a work in progress. Our agencies have evolved in a way and have been partners in the pandemic response. And so today we've asked them to speak to ways in which they're contributing to ending the epidemic. But I want to preface their presentation by saying they are partners in it. They are not the answer to it. We at the table are critically part of the answer to it. And we want to hold the agencies responsible and accountable for the use of the resources, but we should be thinking about ways in which they are not the sole entities responsible for resolving it. So with that, I'll turn it over to my co-chair.
Thank you so much, Dr. Wheeler. I'll just say ditto to all of that, and just recognizing as we launch into this conversation, this series of panels, recognizing that the 57 jurisdictions identified in the EHE, within those are hundreds, if not thousands, of cultures and dynamics, organizations, circumstances, and systems that have to be acknowledged in order for us to truly end HIV. And also recognizing that, to your point, around just the historic nature of dealing with the dynamics and the systems of this nation, particularly as we've seen the South pop up over and over and over again, recognizing that those socio-political systems are so much bigger than HIV, and the necessity of coordination and the connective tissue between the agencies we'll hear from today and where those opportunities are to expand our table even further to truly address the systemic issues at play that may be barriers. And so our first panelist today that we'll hear from is the illustrious, may I use that word? Captain Dr. Robin Neblett Fanfare, who currently serves as director. A few months ago, we would have said acting We no longer say acting, but director, please, of the Division of HIV Prevention, National Center for HIV, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention. Dr. Neblet Fanfare.
Thank you so much. Good afternoon, everyone. So I'm just going to start really briefly. It's been a very busy start to the year for our division, and we wanted to just show two huge highlights and then move on using our data to look at where we are when it comes to EHE. We just recently published earlier this year the continuation NOFO for capacity building in this nation. We expect to award up to $127 million over 5 years to an estimated 15 organizations to help achieve national HIV prevention goals through science-driven, equity-led training, technical assistance, data services, and workforce development. The new CEBA program is scheduled to begin July 15th, 2024. Our new flagship NOFO, lovingly called 0047, was published earlier this year and is set to start August 1st. In our new NOFO for health departments, we integrated 2 previous funding streams. While we do not have the funding or the mandate to expand EHE funding to the entire nation, we can and will be applying lessons learned through EHE across the country. 60 health departments will be eligible for funding. Anticipating level funding, this NOFO will have a yearly investment of $485 million with a total 5-year investment of around $2.4 billion. I'd like to highlight a number of changes that we've made to the NOFO to improve the impact and apply EHE concepts to our whole health department portfolio. We've significantly increased the flexibility of health departments to determine the HIV prevention activities that will best fit the community needs to achieve the goals. We acknowledge the increased cost of operations has an effect on all aspects of work and have made the decision to increase the funding floor in this NOFO. This NOFO also added the ability for CDC to fund other organizations to ensure continuity of critical programs if a health department is unable or unwilling to receive CDC funding. We often hear from our partners that we need to reduce the burden. Combining this NOFO will reduce reporting burden, and we've also moved the start of our NOFO to later in the fiscal year for hopes that we can avoid funding delays felt at the local and state health department level due to continuing CRs. And this NOFO encourages whole person care approaches. Part of this is an investment in syndemic models, allowing up to 10% of funding from this NOFO to be used for activities that support syndemic activities. Now, in this slide, we've heard so eloquently today about critical data points. I won't spend much time on this slide. But clearly, there's still 1.2 million people in the United States, and there were 31,800 new HIV infections in 2022. This goes through the lifetime costs, and you can see that the work that we are doing, all of our agencies are doing, are most importantly trying to save lives, help improve the quality of life, but also it can save money. It's also important to note before we get to some of our findings that over the 5 funded years of EHE, CDC has received a total of $460 million less than requested. Even in the absence of full funding, these investments have shown improved outcomes. CDC found a significant decrease in HIV incidence in 2022 compared to the baseline year data for EHE of 2017 across EHE counties, where HIV incidence has declined by 21%. Congressional appropriations of EHE across the last 2 presidents have made a big difference and had a huge impact. Now I want to highlight some updated information about EHE progress in CDC-funded programs. We'll be focusing on the years 2021 to 2023. So from 2021 to 2023, using EHE funding, health departments conducted more than 831,000 HIV tests. In 2021, we distributed 100,000 free-to-consumer HIV self-tests to populations disproportionately affected by HIV. And CDC's grantees distributed an additional 51,000 self-tests locally. Now, you heard a little bit in the last panel about the Together Take Me Home program. It was launched in both English and Spanish in March of last year. And the goal when this program was first launched was to distribute 1 million HIV self-test kits over 5 years. There's been such incredible demand that as of April of this year, just over 1 year into this program, already 500,000 self-tests have been distributed. Something I'm also extraordinarily proud of, there's a post-survey that's done. And we found in that post-survey of those completing it that 25% had never received an HIV test. So I think what it's showing us is how important these innovations are, how critical the demand is, and how important breaking down traditional models are in order to reach people where they are, where they want to be met. And this project is a partnership in every sense of the word. We're so grateful to our Emory, NASDAD, Building Healthy Online Communities, OraSure, Signal partners across both academia, the federal government, and of course the private sector. So let's talk a little bit about a testing success at the local level, what we're calling EHE on the ground. So for this, I'll focus in Louisiana. In East Baton Rouge Parish, the rate of people living with HIV is 3 times higher than the national average. Fortunately, leaders from across the parish were able to use EHE money to help collaborate and put programs in place that aim to end HIV in the community. One of these programs had a holistic approach that was established where community health workers, including nurses, provided a range of health and prevention services in the community. These services were not necessarily directly related to HIV. They included distributing condoms and PrEP information, screening for HIV, hepatitis C, and syphilis, and also helping with food assistance. This example reflects a priority for us at CDC to reach people where they are with what they need. An opt-out HIV testing program is now also available at 2 local emergency room departments thanks to the EHE initiative. In 2022, CDC grantees used EHE funding to link 84% of persons newly diagnosed with HIV to medical care within 30 days. This includes important practices such as rapid ART, telehealth, and employing peer navigators. Let's examine another local example of EHE in action. During COVID-19, HIV clinics and people seeking HIV-related services had to adapt to a new reality. Telehealth became a crucial and transformative way for some HIV clinics to provide a lifeline to patients. Telehealth can be accomplished via phone, tablet, computer. So let's focus on rural Kentucky. There were 2 organizations that created successful telehealth models using EHE funding. These organizations show how forward-thinking strategies can strengthen health systems, build meaningful connections with people with HIV, and save lives. Live Well Community Health Services in Kentucky launched a HIPAA-compliant telehealth platform. Live Well worked with patients to overcome technological and socioeconomic barriers. Since then, 89% of Live Well's patients have been seen via telehealth, and 95% of their patients are virally suppressed. The Matthew 25 AIDS Services Clinic in Bowling Green, Kentucky, implemented a hybrid in-person telehealth program. And as of 2020, 90% of Bowling Green's active patients were virally suppressed, and that has increased since to almost 95%. The EHE funding supports innovative prevention work. More than 55,000 people have been prescribed PrEP. And between 2021 and 2022, CDC EHE-funded programs have connected with over 260 syringe service programs, 60% of which provide mobile services. So let's talk about a program in DeKalb County. With support from EHE, T.O. Vincent Health Center launched a new PrEP program. This program expanded the reach of the healthcare system by enabling registered nurses to connect more people in DeKalb County to vital HIV prevention services. EHE resources were used to train RNs at T.O. Vincent to offer PrEP through a new protocol. During patient discussions, nurses can now offer PrEP to patients. So over the next year, I'd like to augment and elevate our current efforts at DHP with 3 priority areas that can help us reach all people who can benefit from HIV care. Each of the priorities are intended to advance health equity among all people with HIV or who could benefit from HIV care. And we don't need to be, but I'll be explicit here. We're speaking specifically about how to advance equity for our youth, Black, Hispanic, Native communities, LGBTQ+ communities, including people of trans experience, same gender loving men, rural communities, the South, and people aging with HIV. Equity has to be the heart and foundation of all of our efforts to end the HIV epidemic. I want to emphasize heart because in order for us to reach our goals, we have to think beyond the data and lead with our hearts. You'll see this as a theme in our priorities. We call these priorities the 3 C's: care, connection, and community. Improving care, raising the quality of life for people with HIV, exploring the impact of HIV and aging, supporting activities, linking and re-engaging people in care, and encouraging sustained viral suppression. Connecting people to PrEP, increasing PrEP adherence, uptake, access, retention, especially in communities where prescriptions are low, and engaging communities, creating and sustaining new partnerships and ensuring people with lived experience are heard. To end HIV health disparities and achieve goals, we must reach people in communities disproportionately affected by HIV. And to know how to do this well, we must listen to community and the people we serve through bi-directional community engagement. We were honored to partner with our cousin agency HRSA between March of 2022 to March of 2023, where we held 15 joint community engagement sessions to hear directly from a diverse set of partners and community leaders and discuss community-driven solutions to ending the epidemic. These pictures are from our most recent partnership that we had with NACCHO, as well as the incomparable Southern AIDS Coalition, where we were able to travel to 6 jurisdictions throughout the Southeast, from Memphis to Miami, from Houston to Baton Rouge, to Jackson, Mississippi, and Miami. I forgot one. What did I forget? I said Memphis. Atlanta, our home, sorry. I didn't have to get on a plane for that one, so I forgot that one. So to go to those 6 sites, and we finished this at the end of May. And something that we continually heard there, and these pictures are from some of those sessions, is how important it is for us to be able to travel and come into community, but how important it is that we report back. So we're really honored that later this summer, we're going to be doing 2 sessions, one in person and one virtually, where we will be reporting back to the community as well as health departments what we heard in these spaces and kind of the call to action and next steps. So coming to the end, it's critical that health equity is embedded and central to the work that falls under the 3 C's. We know inequities are often caused by social drivers of health that prevent people from accessing HIV care and treatment. Acknowledging and addressing social drivers inequities must be part of any successful effort to link and relink people to HIV care, connect people to PrEP, and engage community. We can improve HIV care by doubling down on increasing access for all and re-engaging people who are not in care. We can ensure connection to PrEP by closing awareness and access gaps. And we can expand community engagement by reaching and listening to new and non-traditional partners. I want to thank you for having me here today, your continued partnership as we work together to prioritize equity, access, and accountability to ensure all communities, our communities, can access HIV treatment and prevention services in this nation. Thank you.
Thank you so much, Dr. Fanfare. And shameless plug that there will be one more listening session virtually that is in Spanish language. We'll make sure that that information is provided for all monolingual Spanish-speaking Southerners for their voices to be included as well. So we have a lot of amazing panelists, and so we want to be mindful of time. So we're going to ask each of our panelists to try to keep remarks to about 10 minutes if possible, because we want to make sure that there is time for Q&A. So next we will have Dr. Laura Cheever, Associate Administrator of the HIV/AIDS Bureau of HRSA. Dr. Cheever.
Great. So thank you very much for having me here today. It's a real honor to be able to speak to the CHAC. I feel like the entire day and a half has been really setting up for everything I have to say, so I don't have to make too many remarks. It'll be pretty quick. The slide changer? Yes. So So I always like to start with our vision and mission. So within the HIV/AIDS Bureau, we administer the Ryan White HIV/AIDS program, and our vision is optimal HIV care and treatment for all to end the epidemic in the U.S. So completely aligned with what we're talking about here today. And our mission is not just to provide the $2.5 billion every year in resources we provide through the Ryan White and EHE funding, but to also make sure we're providing leadership to assist us in getting where we're trying to go. So those are both key parts of what we feel we are doing. And the way we're really framing it now, and I've talked to a few of you about this, is we're talking about the Ryan White Program 2030. And this comes from us looking at where we are in terms of the Ryan White program and where we need to go if we actually are going to end the epidemic. I don't think that'll happen by 2030. When I say end the epidemic, I mean to continue to take care of the over 500,000 people in the Ryan White program living with HIV as they age gracefully and die of other things, as well as making sure we stop new infections. So it's both of those things. I'm not excluding one for the other. So when we look at our data, we first had our client level data in the Ryan White program in 2010, and we saw that our viral suppression rate was about 69.5%. We had some significant disparities in our data. You can see some of the state-related disparities here. We focused really our program, we asked everyone to focus on viral suppression because people that are virally suppressed can live near normal lifespan with HIV, which significantly improves their quality of life, as well as not transmit HIV sexually to other people. So essentially important, and we focused on that. We were able to, not we, you all, people in the community were able to improve viral suppression rates to almost 90% by 2022. So that was incredibly exciting from us and showed that by focusing, we could accomplish what we were setting out to do. That said, we had disparities initially, and we continue to have disparities, although we have shown that we've been able to close the disparity gaps among some key populations by focusing on interventions for key populations that we were not successfully reaching. So in this slide here, we see across the bottom are some key populations, and across and the bars represent viral suppression rates. So in that first set of bars, the hatched bars, our viral suppression rate was 69.5% in 2010. By 2022, it was almost 90%. And then you can see the lines going across represent the national average. Well, you can see that we have a bunch of bars that are below those averages, and those represent disparities we have. Overall, while we improved by, I can't read it from here, by 20%, I know the first one, by 20% in that period of time, you can see if we go to the second to last set of bars, which is youth, their viral suppression rate was about 67% in 2010, and it improved to 84% in 2022. So big improvements. They had overall a 37% improvement among youth by really helping programs share what they knew in terms of how to reach youth more effectively in our program. But we continue to have disparities for youth, but we've been able to significantly close the disparity gap. So once again, we still have disparities we need to focus on, but we know that by implementing the part of implementation science, the implementers of that, we can actually help reduce those disparity gaps. So I thought I'd hidden that slide, but there it goes. Okay, so the issue we have, though, when we look at how do we end the epidemic, we're doing great among people that we are reaching, that are in our program, which is what those data were, among people that are in care. But as we heard today from Stacey Cohn and other people amplified, I think Jesse and others, we only have a viral suppression rate in most of these jurisdictions, overall in jurisdictions, about 65%. And that gap that you see between 65 and 90 are primarily among people who are diagnosed and not in care. And then we have the undiagnosed, which aren't even counted in that, right? So how do we get from 65% as a jurisdiction to 90 or 95% of the jurisdiction? So we need to make sure we're doing a better job at reaching people that are not in care with us, that are diagnosed and not in care in particular. Why are people diagnosed and not in care? Well, we know some of those reasons. Some of it is stigma. Some of it is being misgendered at the front desk and never going back again. Some of it is going to your pharmacy and you're told that your ADAP is no longer eligible and you're sort of humiliated as they ask you for $3,000 and you leave and you never go back again. I mean, there are a lot of different reasons. Significant mental health issues, substance use disorder issues, homelessness is huge, even among people in care, to really be able to take your medicines and have all of that organized in the way that can actually work for a person is really tough when you don't have a place to live. So we know some of the issues. We don't know all of those issues. We continue to need some of that framework around social science and understanding stigma. How do we better approach stigma? So we have a lot of work to do. But in our program, when we looked at ending the HIV epidemic, we were focused on those 10% of people that we know their name, we know their mom, we know where they live, and they're still not virally suppressed. The people that are not yet diagnosed and how to link them to care more quickly, how to reduce those barriers, how to do rapid start in Ryan White. We've changed our policies to do some of that. And finally, for those people that are diagnosed and not in care, how to reach them, which means we need to be working with different partners, working differently. We need new interventions for those groups. We know that some people are reaching them. So what is happening? How are people changing the way they work? We heard about from Robin today about telehealth as a way to reach people. I can tell you when I was a provider during COVID, seeing patients with HIV, I saw some people during COVID I hadn't seen for years. I mean, through telehealth, which might have been a phone call, but they came back into clinic because we had lowered the barrier, and there they were now virally suppressed in the middle of COVID for the first time. So we know there are things we can do to those people that are diagnosed and not in care that are working. And how do we package that up, implementation science, and disseminate it and implement it? And we know that we can actually do that. And I say that, well, so this I just essentially said, which is leveraging new partnerships, working with new people who are reaching the people we're not reaching that are out of care, because they're going somewhere, they're getting services somewhere, they're connected to someone somewhere. How do we reach them? As well as really making sure we're spreading those interventions that are working so that everyone can have access to them, and engaging community differently. And certainly with EHE, we've been able to do that, talking to people that aren't there, that we haven't talked to traditionally. As the head of our Division of Policy and Data, Michael Carfin, says, everyone not in the room, please raise your hand. We want to hear from you. We need to be hearing from those people. So in EHE, in our first 2 years, and Yemisi Odusanya is here. Yemisi, please stand up, who is our senior advisor leading some of these efforts. In the first 2 years, we started in March of 2020, when a lot of public health people had a lot of other stuff going on, you might remember. But in the first 2 years of EHE, which overlapped completely with the COVID pandemic, we were able to reach about 20% of those people who were either undiagnosed or diagnosed and out of care. And the new money, people had new money for this. In the $2.3 billion Ryan White program, in the first year, we got an extra $70 million. And in the second year, we got an extra $100 million. So it was not a lot of money, but we told people, engage the community differently, work with new partners, and use new interventions. I can tell you that, especially in that first year, even in the second year, what people did in terms of scaling up interventions was scaling up something that had worked in the past as a pilot that they always wanted to do. I mean, there was a lot of capacity and a lot of ideas in the Ryan White program that people hadn't had funding for, opportunities for, that they saw they could do now, and they took it and ran with it. So in our EHE initiative, we can see here that whereas we have about 12% of people that are undiagnosed, we have about 12% of people that are unhoused or temporarily unstably housed in the Ryan program. We have about 22% of people in our EHE that are in that category. And so we know that that is definitely a clue of who we're not reaching successfully normally are people that are unhoused, which I think we understood. We also have about 67% of people who are living at or below the federal poverty line, compared to about 60% in the overall Ryan White program. So once again, we have, we can see that there are a lot of different issues, economic issues and other issues that we need to be thinking about differently, how to reach populations that we're not reaching. And I was really excited that we actually had almost 79% of people virus suppressed by the end of the first year of them being in care and treatment, which we did not expect to be doing so well. So we know that we are actually successfully able to reach these people. We obviously have to do better, but for many people, this is a long road of having HIV for a number of years, coming back into care and achieving some level of viral suppression we were very excited about. So the types of things that EHE recipients do, I'm not going to go through an exhaustive reading of this list, but there was a critical importance on workforce. Someone had mentioned that earlier today. Our workforce is stressed. We do not have enough people, and we do not have enough diversity in our workforce to do the work in front of us. We currently care for over 500,000 people in the Ryan White program. That's over half of all the people with diagnosed HIV in this country. And if we're going to increase our population of people in care, let's say we add another 220,000 people in terms of the people that are out of care, that's almost a 50% increase in who is being seen potentially by the Ryan White program. And certainly not everyone diagnosed and out of care would be eligible for Ryan White, but many, many people will. So if we're really going to have that kind of expansion, we need to be expanding our workforce. And part of that also means that this is an awesome opportunity to make sure we're increasing the diversity of our workforce. So how do we get different people working for us, and how do we really expand who is doing it and how they're doing the work? So I'm excited about that. And we're learning something through EHE. We've already heard about telehealth. I think the telehealth was huge. Rideshare programs really expanded. Oh, I'm at time, and I'm at time. So let me go for one. You can continue to read that. So in ending, I just want to point this slide out, that one of the challenges we have is we've really not had any significant increases in the Ryan White budgetary lines since 2013, except in EHE. So if we look across here, part A, B, C, D, they're all pretty much been maintained, as we say in the federal government, for many, many years. During that time, certainly we've had significant amounts of inflation, so we're asking more people to do more with less. And so what I'm really asking our Ryan White recipients to do is to figure out how to stop doing some things they're doing now. Everything they do needs to be focused on keeping the people that are in care and expanding care to all those people who aren't in the room. And so that means that we're going to have to stop doing some things to do other things. And that is a really tough thing to ask an organization to do who's doing everything they can to stay afloat. So it does mean that we need to think differently and reprioritize differently. Certainly in some of the aging work, I've been asking our recipients to say, well, where else does the government fund aging related services, and how can we take better advantage of all the kind of work that ACL does? You'll be hearing from ACL later today. How can we take advantage of those other resources in the community? Because I don't know that we're going to get a lot more money in HIV specifically, but there's other funding in the community. We need to take advantage of it. Thanks very much.
Thank you very much. Next, the Director of the Office of Health Center Investment Oversight, Bureau of Primary Health Care, Ernia Hughes.
Thank you so much. Dafina promised to roll her eyes at me if I went over, so you'll have to take a look at that. So I just want to thank PACHA for inviting me into this conversation. I believe that these PACHA meetings have really offered me an opportunity to fortify my relationship with my federal partners, but also just to really hear from you, your curiosity. Marvell, you asked the best questions when we were in Texas. I welcome your interrogation of our data. I'm going to do a little bit of a disclaimer. I think I'm going to disappoint you with some of the data, so I'm going to manage your expectations from the start. But next time I come to PACHA, I'm going to have some patient level data that will be more satisfying. I'll be able to share with you the health center story from that perspective. What I would submit to you is that community health centers aren't the answer, but they are an answer. And so let me tell you a little bit about them. And I'll take you back to yesterday's site visit to Whitman Walker. Again, I described Whitman Walker. They are a crown jewel in the health center family. You would agree, right? That was an exceptional display of how you do everything right, how you think of everything. And do you remember that their president said that this is essentially a break-even proposition, right? And do you remember all the things that they were doing for people? They were taking their kids to school. They were giving them backpacks. They were feeding them. They had patient navigators. They were just everything that took care of the whole person. And let me tell you the shoestring budget that happens on. Whitman Walker receives a grant from the Bureau of Primary Health Care, an operational grant, and it's $2.7 million. They get an EHE grant from us, which is about $300,000 a year, and that started in 2020. And you know, it is a health center that takes care of the whole person, right? So it's not a health center that is exclusively dedicated to the delivery of HIV care, right? There are many, there are folks who come in who have a variety of things that they seek primary care for, right? And so again, you heard all the services that Whitman Walker does. In addition to that, of course, they have insurance, and also their executive director told you that they are operating in an optimized state, right? That the conditions are optimal for them to do all the work that they do. So that is unique. So let me talk to you a little bit about, so if you were impressed, let me share with you what happens in other circumstances across the country where the conditions aren't optimal, where the funding has been less than robust, and still I submit to you that health centers are an answer. So under the EHE initiative, we are charged with investing in health centers to do three very concrete things: to increase HIV testing, to increase PrEP prescribing, and to connect individuals to care who test positive for HIV within 30 days. My friend, Dr. Cheever, we were in a conversation, she probably doesn't even remember this, is probably a few months ago, and she said to me, you can't PrEP prescribe your way out of the epidemic. And so, so that's true, right? You got to take care of the whole person. And in so doing, we really do have a shot at this. We have some hope. And again, I say to you that health centers are part of that hope proposition and position to not only to actualize implementation science, right? So there, it is concrete work that happens inside a health center, and they're prepared to do the work to pull, roll up their sleeves and bring heft to the effort. So here's what integrated services look like in a health center. Look familiar to you, right? These are all the things that are important to caring for the whole person: enabling services, improving patient outcomes. I have to give a shout out to the team who work in the investment office. They are behind me. They are exceptional. They bring their best selves to this work. And these are the things we think of ourselves as the shared accountability between how we work with health centers and how they expect us to, how we expect them to work with communities. And so again, this slide represents that equation, if you will. So we've been investing in health centers under EHE since 2020. And to date, it's a total of $157 million. We have cohorts that started in 2020. And so it lends itself to a natural control group, if you will, right? So we've got these group of health centers, and now there are 411 of them cast against the other health centers in the health center network that don't receive funding. And so it allows us to test, does our investment work? And so I'll show you in ways that it's working. By the way, there are about 1,400 community health centers in the country. Every single state and every territory has a community health center, and there are 15,000 sites across the nation. So here is evidence that the investment in community health centers work, right? So we've got, you show that, and here again, Marbell, you're going to interrogate my data, right? When the time comes, right? That, we show that there is success here, an uptick in testing, an uptick in being connected to primary care, an uptick in PrEP connection. These are 22 data. We have our hands on 20. We're always our uniform data system is always a year behind, right? And so we've got our hot little hands on our 23 data. I can't show it to you yet. They will string me up if I show that to you now, but the data for 23 looks promising as well. So take a look at this map, and I wonder how this speaks to you. This shows you the spread of health centers across the country, including health centers that receive the primary care HIV investment cast against the other health centers that do not. That's not a map that I would say we declare victory around, right? So there are gaps here. There are gaps to fill. There are communities to serve. There are communities that are underserved. We've talked a little bit about the fact that the investment that we received at the federal space has been inadequate. So as feds, we are prohibited from lobbying. So this is not lobbying, it's educating, right? That's the way that we describe what we do. And here again, we are doing the work. We're doing the work with not the amount of funding that would allow us to bring additional heft to the effort, but still we persist. Uh-oh, I got my first eye roll. So here are the, so here's the difference making. Like here's the evidence that the investment makes a difference, right? So you see health centers that received the award cast against those that did not, and you see how it's a favorable outcome, right? Connecting to 30 days. So as a group, we've been talking about the fact that we are dissatisfied with this particular measure. Connecting someone who's diagnosed within 30 days is inadequate. Our desire is to support a health center to connect someone to care immediately the same day. I'm going to skip through these because I want to show you Dr. Prep, which is really an important little video. I think that will tell you the story of how health centers use their money in a creative way to do a campaign. And in this particular instance, well, let me tell you a little bit about how we get smart about what health centers do. They report their progress to us through progress reports. And so no surprise, community health workers have been the star of the show in terms of connecting individuals to care. Opt-out testing is an important way that health centers are doing their work, regularizing sexual health care inside primary care, syringe services. So here we go with Dr. Prep. So Dr. Prep is a series of 5 videos that was produced by a health center in Puerto Rico. And so my friend at the control desk is going to share this video with you. So these videos were produced in English and Spanish, and this health center in Puerto Rico really did see an uptick in this character is relatable. I think if he plays the video, you'll see how he's a rather charming character indeed. And so Health Pro in San Juan really was able to get additional patients in by using this video.
Pedro. Hey, hi Rosa. Oh, how good to see you all. Hello everyone. Thank you for joining the Health Pro Med Live. Here we have the first question. Thanks, Jaime. How does PrEP medication act in the body? Well, let me explain. PrEP works by blocking an HIV enzyme that in turn prevents HIV from copying itself in the body. When the virus can't make enough copies of itself, it still remains HIV negative. Protect yourself from HIV and live a healthy lifestyle. If you want more information, request a consultation with Dr. Prep by calling 787-710-8800. In Health Pro Med, we know how to take care of you.
Good stuff, right? Yeah. Okay. Will you indulge me for 5 more minutes? Well, not even 5 more minutes, two more seconds with a call to action. And Dr. Wheeler influenced me in this instance. Community health centers are led by patient boards. It is a requirement that 51% of the board of directors be individuals who receive their care in the health center. So my call to action really is for individuals to think about joining a health center board to influence the direction of the care delivered inside a health center. Whitman Walker, I bet you that board is all over in terms of influencing the level of care that's received. I am convinced that is the board of directors has influenced what you saw yesterday. And so it is such a prime opportunity for community members to be on the front line of ensuring the kind of access that communities deserve across the country. Thank you again for indulging me a little bit. I got 2 eye rolls, I think, and so I will pass it on to my federal colleague.
Thank you. So next we have Dr. John Oguntomalade, and John is with, actually Dr. John, Ending HIV Initiative Coordination Lead in OIDP, and Office of the Assistant Secretary. Welcome.
Thank you very much. And it's such a pleasure to be here and honored to be part of this PACHA meeting. As EHE is initiating its 5th year, I'm really glad that we're having these conversations about EHE because it's of critical importance for us to understand what is working, what is not working, where are the gaps, what are the opportunities, what are the best practices, and for us to see ways in which we can optimize this response. It's been a great pleasure to be here and to serve with this distinguished federal panel. Our role in EHE in the Office of the Assistant Secretary, Office of Infectious Disease and HIV/AIDS Policy is not a role of someone that is directly funded to implement EHE activities, but our role is more of a coordination role across federal partners to ensure that we minimize siloed implementation of these activities and so that we can have optimal program outcomes for EHE. So it's just been a pleasure being in this role for about a year, started July 2023, and just working with my colleagues in CDC, HRSA, NIH, IHS, and even our colleagues that do not directly receive funds for EHE in SAMHSA and HARD, working closely together to optimize this response. So my remarks is going to be in three main sections. The first is the overarching role of OIDP in this response and where we are after 4 years. Then the second piece will be the importance of community engagement to optimize an equity approach. Then lastly will be best practices from rural engagement and strategies moving forward to end the HIV epidemic. So talking about the role of OIDP in this response, as I mentioned earlier, our role is mainly involved in cross-agency coordination of the EHE initiative. We facilitate collaborative efforts of EHE-funded agencies and the integration of attributes of non-funded agencies to optimize this response. We're not directly funded to implement the initiative, but through some of our resources, through the Minority HIV/AIDS funds, we support the EHE initiative through support of workforce training, technical assistance effort, status neutral and syndemic approaches, and also addressing the social and structural barriers, including stigma. And of course, we heard earlier about the AHEAD dashboard that was well presented today. These are some of the activities within our office. And of course, I need to mention that we have regional teams, endemic teams in Region 4, Region 6, and Region 9 that actually work beyond those regions, expanded beyond those regions to optimize the response and to ensure that we have collaborative efforts within the regions. So also within our office, we work together for the integrated approach across the national plans. We have the National HIV/AIDS Strategy that Director Ruiz talked about earlier on. We have the viral hepatitis plan, we have the vaccines plans and the STI plans, and we work across the board to ensure that we have an integrated approach to develop and implement these plans. So earlier today, we heard a lot about the data, and I wouldn't go into details of the data because we already heard so much about it. But I think one important thing to note about the data across the board, comparing from 2018 to 2022, is that we've been seeing an overall decline gradually, even decline in many of the subgroups. We see that we seem to be moving in the right direction, but we're not moving fast enough and we're not moving equitably enough. And these are things that we really need to look at closely for us to move towards ending the HIV epidemic. So these charts, and I'm sure you're quite familiar with them, we wouldn't spend too much time on them because the previous presentations talked a lot about the data. So as we noted that there's a need for equity in our response. And for us to have this equity, it was very important that we're engaged in community engagement activities. Because for you to know how to bridge the gaps in certain communities, we do not just develop plans and serve it to those communities, but we have to work hand in hand with those communities to know what are those challenges within the communities and how can we work closely with them to mitigate those challenges. The photos that you see out there are just photos of one of the engagements that we had in Georgia. And you can see that this was a collaborative effort of CDC, HRSA regional office, and the OASH engagement teams and the community to have a very, very engaging partnership with the community to understand what are the challenges, what are the opportunities, and how can we move this initiative forward in an equitable way. And since within the last 10 months, we've been able to reach out to about 30 of the 57 jurisdictions. We've had about 30 EHE leadership engagement consultations. We've had about 43 service delivery site visits, and we've initiated about 18 local EHE jurisdictional listening sessions. And all this is so that we know what is happening on the ground. And we also work with the leadership to understand how are they thinking about their data? What are the gaps? What are the challenges? What are the opportunities? And how are they thinking about pivoting towards optimizing the response within their local jurisdictions? And those were the reasons why we had those engagements at the jurisdictional level. And you can see towards the right side the places that we went. So now that we talk about equity, equity is so important. And as we engage with the community, it was important for us to learn some key things from the community. And in this particular table, we can see some of the things that we learned from the community within the rural jurisdictions. We were able to disaggregate this into structural, systemic challenges or factors, provider level factors, and community level factors. And in some of the rural states, all these were present, and in some others, some of them were present and some of them were not. So when we look at the systemic factors, we can see that stigma, limited access to rural in rural areas, human resource capacity was a challenge, and issues of connectivity were also challenges that they talked about. We heard about health professional shortages, and we also learned that there were many instances where there were not enough CBOs that represented communities that were disproportionately impacted with HIV, and they felt there was a need to support these CBOs the more because they had credibilities with the community. Then there's been an uptake in PrEP within the primary care setting, and we can see the work that our health centers are doing, but they talked about the importance of really increasing this uptake of PrEP within the primary care setting. Then integration of wraparound services was so important because the communities that are disproportionately impacted with HIV have so many vulnerabilities that if we're going to have sustainable HIV program outcomes, we need to help them with the various social challenges that they're going through for them to stay virally suppressed. Then limited harm reduction programs, criminalization laws, these were all part of the systemic things that we heard back from the community. And when we talk about provider level challenges, we heard a lot about health professional capacity, and this can be looked at in multiple ways. There are some health professionals within the rural setting that are not comfortable dealing with HIV. They're not comfortable working with patients to determine eligibility for PrEP. There's so many opportunities to expand opt-out testing within these communities and screening for eligibility for PrEP. Even with some of the providers, there was limited comfort with the use of telehealth. Even when those equipments were available, there was limited comfort in the use of telehealth services to expand services within the rural community. And they needed a lot of help and support in addressing stigma and respectful engagement of the LGBTQI+ communities. And there were also issues associated with cultural humility that they needed to understand how to approach the communities that they were serving effectively. And we also learned a lot about state laws. There were individual state laws that limited what health professionals could do. And based on that, they were reaching out to us to find out ways in which we could support them in all this. When we look at the other factors, which are community factors, there were factors that were associated with stigma, issues of confidentiality within the rural setting, medical mistrust. Almost everywhere we went, we heard about housing, and housing again, and transportation. The need of greater engagement of people with lived experience was something that we heard a lot within the rural environment, that this was something that we needed to do more. Then limited navigation and case management system. And even when telehealth was available, many of the people that would benefit from telehealth did not have equipment to receive telehealth. So that was a barrier for them, and limited access to wraparound services. Then when we look at it as a whole, in almost all the communities that we went, they talked about the influence of the local politics on public health interventions. And this was a very critical need that they had, and we had to work with them on various strategies to navigate this so that evidence will continue to drive public health policies. So if we look at the next, so although we talk about challenges and opportunities across the various rural communities, here I also want to talk about some of the best practices that we got to see in these communities. I usually try to give a shout out to those people that are really doing some great work and innovative work. And you can see some of the signs or the logos of some of those organizations across the 7 states showing some of the great work that they're doing. For instance, in Mississippi, there's a hospital that many of you may be familiar with, Jackson Hines Comprehensive Health Center in Jackson, Mississippi. When we looked at the number of people on PrEP, they had more women on PrEP than men. And in almost all the facilities that I've been to, most of them, the highest number of people on PrEP were men within the MSM community. But here, because of intentional efforts to reach out to women, they were able to have more women on PrEP. And I thought they had some great best practices. When we were in Oklahoma, at the Oklahoma City Indian Clinic, they had the state-of-the-art pharmacy facilities, and they had some community-based, okay. I take a deep breath, okay. So we saw some great pharmacy activities in Oklahoma, in Kentucky, in the 550 clinic, we saw trauma-informed care approaches to increase PrEP uptake. In Missouri, Williams Associate, they had this culturally informed practice to reach out to young Black MSM community. They had some great practices there that really welcomed the young Black MSM community. I wouldn't bother to go through the rest of them. I'll just move on to the next slide to just talk about the way forward. So after learning so much in the 4 years of this initiative, I'm moving into the 5th year of the initiative. I know that we don't use the pandemic as an excuse any longer, but in the 4 years of implementation of the initiative, we've had challenges with the pandemic, in almost significant challenges in almost 3 of them. And if we look at the data that we have right now, and although we're not where we want to be, there's been a lot of significant progress despite all the challenges that we've had throughout these 4 years. Although we know that we can still do more, there's still much more work to be done, and also there's still the need for us to move in the direction of equity. So we need to find ways to optimize the lessons learned and innovations, not just across the 57 jurisdictions, but even beyond, so that we can continue to make progress in the country, build on the momentum and gains over the last 4 years, and have enhanced coordination on the federal level, on the state level, on the county level, so that we can accelerate the equity approach. As I mentioned earlier, we heard a lot about housing. Innovating housing solutions are things that we need to do. Then strengthen health workforce capacity is something that we need to really look at very carefully, both in quantity, in quality, in diversity, and the motivation of healthcare workers. Then supporting CBOs that represent the community, that can give us high yield programs because they have credibility with these communities. Then the last one I'll just mention, because we need to wrap it up now, is that the funding that we receive for EHE, based on all the things that we've been hearing, to a large extent, it seems to be level funded right now. So we have to find ways in which we can optimize public-private partnerships to release or for resource mobilization to do things that the federal funds will not do. I saw a great example in St. Louis, Missouri, where they built a 50-unit HIV housing complex based on raising money from public-private partnerships. And I think that this is an aspect that we really need to encourage, even as we begin to find ways to ensure that we have increased appropriations to do the work that we do. Thank you so much for listening. Hope I didn't take too much of your time.
We have a bit of time for questions from members and from federal partners. Okay, Mackenzie.
Thank you, Daryl, and thank you everyone for being on the panel. Really appreciate you being here with us, and I think you're doing a great job. My question has to do with, I've been doing a bit of reading about contingency management lately, and it seems like there have been a lot of studies for a lot of years that show that it's effective, perhaps highly effective, in driving adherence and viral suppression. I was wondering what each of you think about using contingency management to help us end the epidemic.
Sure, I can start. I actually used to work in, I was a medical director of a methadone program for a long time. And certainly I think there's the contingency management is a little bit complicated. Certainly in the context of the Ryan White program, we can't make cash payments to clients. It's prohibited in our statute. And I think for contingency management, it doesn't have to be cash payments. The department has a whole policy on contingency management. It can be gift cards and other things, but I think that's one thing just to consider there. There's no, there aren't prohibitions specifically around contingency management, but the concept is, when do you do it? When do you stop? Do you do it for everyone? And Ryan White, if you're going to do something for someone, you need to be able to do it for everyone. I think when I've talked over the years from a substance abuse treatment background, which is a little bit different than what you're talking about, there's also been a concern expressed in the past about concerns about coercion or feeling of coercion, because if you're trying to get someone to do something for their own good, right, and that's what contingency management usually is, someone who is living at or below the federal poverty line, you're saying, I'm give you $50 if you'll do this, and I'll give you $100 if you do it next week, and I'll give you $300 if you do it by, in 3 months from now. That there's like a coercive element that's a little bit different for people that are of different amount, of different, or sitting in different socioeconomic seats. And so that's just another concern. So I think all of those have to be accounted for, but in terms of whether people should do it or not, I think it really depends on what your population is and what you're trying to achieve, and sort of what your long-term plans and goals are around that contingency, how it's being used. But I don't a priori have anything for or against it. I think there are a lot of considerations.
Marvell, thank you.
My question is for Ms. Hughes. I know you were waiting for my question, but I wanted to break it
Time's
up.
Thank you.
I wanted to ask a kind of a different tone of a question for you. I looked at your bio, and I know you've been doing this work for a long time. For new leaders, can you give us hope for the future?
See, it is the best question, right? Thank you so much. So, really, thank you so much for that question. I have actually been doing this work for 30 years. I was the director of HIV services in a community health center in Boston. Boston, by the way, is one of the birthplaces of community health centers. And so for me, it was the connection to community that inspired my passion and my hope, and that's endured. It has never dimmed. In fact, the team that I work with, I think they find me a little bit of a pain in the neck in some ways, because we all have such energy for this work. And it really is, I think, because I see myself in those communities that we work with. And, I see my siblings and my parents, and all of that just feels so meaningful. And I think there's the opportunity to lead from whatever seat you sit in, and just to kind of embrace that. And I felt inspired by you in Texas, and so thank you so much for that.
We'll receive the 2 questions. If you could be succinct, Paul, and then Davia.
I have 2 questions. And first, thank you so much for your presentations. I was struck by the fact that all of you talked about flat funding and about the challenge that flat funding brings to you. And the question is I don't think it's going to change. And so how are we going to address this as we identify more and more people living with HIV? The second part of this question is around 340B funding. At our meeting yesterday with Whitman Walker Health, I was struck when she said that 30% of her budget was 305B and 304B. And so the question that I have is, how does that factor in to all of the work that we have in front of us? And what should we be doing to either support it or codify it, or make sure that we're able to understand the impact on the services that we provide?
So I'm going to just jump in and start. So according to NASDAQ, if you actually look at 340B funding for the ADAP program, it accounts for almost 50% of ADAP funding now, in terms of the overall ADAP budgets nationally is from 340B. So so we have been able to, so that's exactly the underlying. Since 2013, what have we done? We've made sure everyone is maximizing the expansion of Medicaid and ACA. since that time, and that they've really maximized how they utilize their 340B funding. Now, for us, we can clearly demonstrate, and all of you that have site visits and get frustrated with us, all of program income from the runway program better be spent for purposes of the program and nothing else, right? And so people, it makes them crazy, but it's exactly what 340B is supposed to do. So there's a lot of press about 340B, what it's used for or not. How do you measure whether or not people are providing care? We can demonstrate that in the Ryan White program, where that 340B program income and rebates are going to. So that's the first thing, is the integrity of the program is something that we really focus on. But in terms of level funding, it's exactly what I said. In the Ryan White program, the beauty of the program is that all of that planning and priority setting is happening at the level of the jurisdictions. And the jurisdictions that have the most funding, actually, although more money goes to our state program, $900 million is carved out for ADAP. So really where we have the most funding that is for overall for programming is in the Part A in the cities. So in those planning councils, they need to prioritize how they're going to spend money to reach those people that they're not reaching. So once again, it really is about getting everybody in that room to understand who's not in that room and what their needs are, and how that's reflected by the people that are on that room that might have had a long journey to get there. But they're going to have to stop spending money on something in order to spend money on something else. And it's not about cutting fat out of the program anymore. It's not about any of that. It's about really not funding something they're currently funding that somebody needs, in order to fund something so that people aren't dying of AIDS, which is happening, as we've heard. When people were dying of Mpox, and there were people that should have been in the Ryan White program and had high CD4 counts and suppressed viral loads, and they weren't. Those people died because they weren't connected to care. And so we need to do something differently in terms of when you have people sitting at the table who have fought to get there, thinking about what are they depending on that we're going to stop funding through Ryan White in order to fund something else.
And last question. I don't know if I'm the last question. I think I am. This question is for Dr. Cheever. You mentioned different partners, different interventions, and lower barriers to care. And I could not agree with you more, specifically when we're talking about Latino communities and communities of color. What I do find alarming is that a lot of the interventions that we're currently using are completely outdated. Interventions that are specific to communities of color, when you look online for these interventions, they've been around for 10, 15 years, and they do not meet the current needs of our population. Under the EHE funding, I think that it was such a great time for community-based organizations, federally qualified health centers, to have funding to be innovative surrounding innovation. So I have heard some new innovative research for these communities in terms of interventions. How do we get these interventions out, and how do we gain accessibility to these interventions at a nationwide level? Because those newer innovations actually, which is a great success story, came out of EHE funding. Now, what are we doing to publish those interventions so that Latino communities and communities of color across the nation have accessibility?
Yes, so that's a great question. So the first thing we've been focusing on this for a while. The first thing we're trying to do is make sure those interventions are shared as quickly as they're happening. And Yemisi Odusanya, once again, stand up. Yemisi can talk about at some point when you want to talk to her about the we had regional technical assistance in where different jurisdictions from EHE got together in a facilitated discussion, heard from each other about what was working and working really well that they were excited about, and they all left with a plan to implement something new and different when they went back home. So that's real time. We also have something called our best practices compilation, where we have these interventions that are working, and most of them are relatively new interventions. We get them posted in a way on the web that people can actually use them. So we make sure that people can pick up and use what they're looking at there. Things like the Fenway Health in Boston has been our E2I is one of those intervention groups, we call it. But making sure, like, short videos and things, like, what does this look like? And having different people in the community and in the clinic talk about what they're actually doing. How do people learn now? So we're trying to make it as user-friendly as possible. But if you go to targethiv.org, you can go to best practices compilation. There are over 100 best practices there, and most of them are relatively new. You can sort by different populations, by what kind of clinic you have. And it'll talk about things like what kind of resources you need, what kind of leadership you need, what kind of staffing you need to do these interventions. So we're trying to make it as user-friendly as possible. We will continue to work on this. We're heavily investing on how to make sure that we're disseminating things in a way that people can actually pick up and use them, and then studying whether people are picking up and using them. If they're not, what is or isn't working. So
Okay.
that's a great question, and that's right where we want to be right now.
Thank you very much. As you can, I mean, undoubtedly the panel could go on and on because you have so much to offer. And thinking about the day, you're bringing to life what's actually happening through your portfolios. And so we appreciate that. We have 2 more panels and we were supposed to have a break, but we shot through time. So I think we get 3 minutes for you to do whatever you can do in 3 minutes. If you give you 5, then it's going to be 8. So you get 3. Thank you, panel.
Produced by the U.S. Department of Health and Human Services.